And now I'm going to hand things over to Valerie Pieraccini of UCP of Central Arizona, who's our moderator for today's panel with 3 top researchers on cerebral palsy. Before she gets going, let me just tell you a little bit about Valerie. In addition to serving as co-chair of the UCP National Board's Ad Hoc Research Committee with Dr. Michael Kruer, Valerie has worked for UCP of Central Arizona for 27 years as a pediatric occupational therapist. She currently serves as director of the therapy program and early learning center. She's an adjunct professor for the Huntington University OTD program, and her current focus is on designing outpatient care pathways for cerebral palsy and related developmental disabilities. Valerie, the floor is yours.
Hi, thank you, James. It's wonderful to be here. So I'm really pleased to bring to all of you the current research that gives us evidence for the diagnosis and early treatment for children with cerebral palsy. As with the earlier panel today, we're going to follow the same process. I'll be offering a brief introduction of our different panelists, and then we'll go into their different presentations, and each one of those will be about 12 to 15 minutes as time allows. And then we'll go into our question and answer segment. Just a reminder to all who are watching, please enter your questions into the question and answer function. And we promise we'll get to as many of those as possible, for sure. So what I want to do is just provide a brief bio of each one of our panelists, and then this will be the order that they will present. And then, as I said, we will give opportunity for questions, but you can go on ahead and put those in the Q&A as we go. So first up is, I've had the pleasure to meet Dr. Adam Rozumalski. I worked on that. I talked to Mark Gormley, by the way, Adam, just to make sure I pronounced that right, and then I stumbled. He's the Director of Operations for the James R. Gage Center for Gait and Motion Analysis at Gillette Children's Specialty Healthcare, which is considered the busiest clinical gait lab in the country that's organizing, conducting, and disseminating original research in the fields of biomechanics and clinical outcomes, as well as he's teaching and training engineers and clinicians across the globe. Dr. Rozumalski's presentation today is titled Collaboration and Control, which are keys to improving research in cerebral palsy. Our next presenter will be Diane Damiano, who I've had the privilege of also getting to know of recent. She is the Clinical Center's Chief of the Functional and Applied Biomechanics section within the Rehabilitation Medicine Department at the National Institute of Health, or as we know, NIH, in the U.S. Department of Health and Human Services. Diane's research has focused on the design and investigation of activity-based rehabilitation programs and development of robotic devices to promote optimal motor functioning and enhance muscle and neural plasticity in those with cerebral palsy. I know her laboratory has pioneered the use of mobile brain imaging technologies to investigate cortical activation during the emergence of motor skills in infants and children with and without cerebral palsy. Although after talking to Diane, I do know that her recent interest and passion, so she is a person after my own heart, is that she is interested in early identification and intervention for children with cerebral palsy. So her presentation is titled Efficacy of Early Therapy for Children with Cerebral Palsy. And then last, but certainly not least, and I'm honored to call him a good friend, is our final presenter is Dr. Michael Kruer. And he is the Associate Professor of Child Health, Genetics, Neurology, and Cellular and Molecular Medicine at the University of Arizona College of Medicine here in Phoenix. He is the director of the Pediatric Movement Disorder Program at the Barrows Neurological Institute and Phoenix Children's Hospital. Dr. Kerr is a pediatric movement disorders neurologist, developmental pediatrician, and molecular geneticist. His most recent work has been lauded wildly but widely in the nation of recent. It was published in the Nature Genetics in 2020, and it was groundbreaking work that provided strong evidence, and the strongest evidence actually to date, that 14% of cerebral palsy cases can be linked to rare genetic mutations. Although I know Dr. Kruer shared with me, they believe it's more than 14%. His most prized recognition has been the receiving of the Laura Dozier Award in 2019 from UCP of Central Arizona. Dr. Kruer's presentation is titled Biomedical Updates for Cerebral Palsy. Again, the extended bios are actually, for each of our speakers, can be found on the annual meeting event page at ucp.org under the News and Events tab. So if let's get started. Adam, I'm gonna just let you take it over from here.
Well, thanks, Valerie. It's honored. It's my honor to be able to start this off today. Thanks for having me. Let's make sure I can share everything. Let's see, are you seeing the presentation now? Okay. And is it in like the regular view, not the presenter view, because that gets annoying?
You're good. It's good.
Okay. Thank you very much. So when kids with CP come to the Center for Gait and Motion Analysis, we're typically assessing whether or not they need some kind of intervention to their musculoskeletal system. We accomplish this by doing a quantitative assessment of how the kids walk to see how their legs are functioning. In order for us to make the translation from this information to clinical recommendations, we need good quality research information to guide our decisions. And there's several components to good quality research, and I'll go over that today, as well as some complications involved in doing research on kids specifically with cerebral palsy. When evaluating the effectiveness of a treatment, it's important to provide context. And this is done by comparing the results from a group of participants who received a treatment to a group of participants who did not, usually called the control group. If I sprinkle water on my kids' feet every day when they're born to when they're 16, I can say, look how much I helped them grow. I can even repeat this with many children and get the same result. But I need a control group who did not get this daily watering to show that children grow just fine without it. A group from the University of Michigan sorted through hundreds of manuscripts looking for case control or retrospective cohort studies. These are studies that by definition require a control group. And they found that about half of those studies were missing one. So this is a real problem. The idea with the control group is to get counterfactual information. In other words, what would have happened if we did something else? And it would be ideal to observe a research participant for some time without any intervention, and then go back in time and provide an intervention and see if there are any differences in the outcome. Since we can't do that, the best alternative is to have two participants, or better yet, two groups of participants who are closely matched before the intervention. And that way we can try to tease out the differences after the intervention. And while this is especially important in the clinical sciences, it's actually important in all sciences. The problem we run into is that a properly matched control group can be hard to find in CP. If a child comes to our institution and there's an intervention that we feel is appropriate, it'd be unethical to withhold that treatment just to see what happens. One way around that is to actually collaborate with other organizations. There may be two clinical centers with differing ideas of what they feel is an appropriate intervention, or even if they are able to provide it, or they feel it's appropriate, are not able to provide it. There may be community organizations out there that are in touch with kids who don't think they need an intervention. Perhaps we can reach out to them to measure how those kids are doing. And due to the complexity involved and the large amounts of data that can be collected, it can be helpful to use advanced statistical techniques like machine learning to be able to automatically sort through it all and identify those matched control groups. To add to this complexity, we're talking about kids who grow with or without that watering. As they grow, some of their issues get better, like the efficiency of their movement. Some get worse, like joint contracture. Some issues like torsions in the bones can go either way. It's important to note the changes we're observing are due to the intervention that was done. In CP, this can be difficult to understand. The families that come to our institutions are looking for ways to improve their child's life. And something's usually done, often many somethings. We don't see the families who don't want intervention, so we can't measure those kids. The concept I think everyone who's familiar with CP knows about is heterogeneity. No two people with CP are exactly alike. This makes predicting the outcome of an intervention difficult. There's heterogeneity in how the children present, in what kind of treatments are recommended, and in the response to those treatments. There's also heterogeneity in the desired outcome. Not all physicians are equally aggressive with their treatments, and not all patients want the same future. It's important to take that into account, the intent of the treatment, when designing our studies. As an aside, it's important to identify the intent of the treatment before conducting an experiment as well. Oftentimes, researchers will look at data and say, yes, that's what we thought all along. And it's important not to fall into that trap. The upside to this is that we can actually improve the robustness of our retrospective analyses with heterogeneity. Once we've seen a lot of kids, we can look back and see some that present similarly. But there are different treatment paths that they go through, and we can try to assess what was best. Now, a quick story about our institution, who's tried to learn from our mistakes. Some time ago, we wanted to look at the outcomes from a specific surgery, in this case, the intramuscular psoas lengthening. Many kids with CP walk in a crouched posture, where the hips and knees are flexed more than they should be while they're walking. And it's thought that by increasing the length of this muscle that goes in front of the hip, it might help them walk more upright, but not everyone agreed. So it was decided to not do a prospective study due to the ethical concerns I mentioned earlier. So the researchers looked back in our database and analyzed kids who had come in before and after surgery. They found a relatively large group of 71 limbs on which they could do their analysis. One of the issues with this group of kids is that surgery is rarely done in isolation. Oftentimes, the kids have several surgeries at once in order to efficiently do everything that needs to get done. So they did not use a control group, but they did compare the outcomes to a group of kids that had different surgeries. So while not a control group, there was a comparison group. They found quantifiable improvements in the group that had the psoas lengthening surgery, but the comparison group also showed some improvements. So it was hard to know if the improvements that were seen were actually due to the psoas surgery. Maybe these were just two very different groups of kids to begin with. A few years later, we decided to repeat the study, but this time we wanted to have a better control group. So we had our surgeons define a specific clinical criterion that the patients would need to reach in order to be considered good candidates for the surgery. When we looked back in our database, we found plenty of kids who met the criteria and got the surgery. But due to the heterogeneity I mentioned earlier, we also found a bunch of kids who met the criteria and for one reason or another did not get the surgery. This gave us a pseudo prospective control group that we could look back in our data and compare to. When we did that, we found that the two groups had very similar results. After that, we thought, well, maybe there's a better way to define the surgical criterion to know who will do well with this specific surgery. So we worked the problem backwards. We found the kids in our database who had the surgery and used statistics to define the best criteria that would separate the good and bad responders. We then used the new criteria, just like we did the old one, to find a matching control group. The results showed that if we selected the kids properly, we were able to show a 14% improvement in the rate of good outcomes with the surgery. Using those advanced statistics, the criteria can be transformed into the map shown here. You can see the kids who did well with the surgery tend to be in the green area, and the kids who did poorly tend to be in the red, and the kids that our algorithm struggled with were in the gray. So now when a new child comes through our gate lab, we can see where they fall on this map, and that can help us guide our clinical decisions. This type of analysis can be done with any number of interventions. So we were able to learn a lot over the years about proper research technique, but there's still a drawback to this kind of work. We only use data collected at our institution. We can guess, but we don't know for sure if these results hold true for the general population. That's why we need collaboration among a variety of institutions. With alternate patient populations, we can find better and larger control groups. Due to the different treatment paradigms at different institutions, we can directly compare the effectiveness of different interventions. And because evaluation techniques vary between institutions, we can see what gives us the best information for our clinical decision-making. To help with this, the CP Research Network is being developed, and the other panelists here today actually have a lot to do with this. The goal is to provide a platform for collaboration and standardization across institutions so that we're all collecting the same information the same way for all of our kids with CP. This will be vital for conducting the types of large-scale studies we need to figure out what works and what doesn't for these kids. So I encourage you to encourage your institution to get involved if they get the opportunity. Thanks. And with that, I will send it over to Diane. She can take it away.
All right, thank you, Adam. Diane?
Hi, let me get my screen up. Oh, it says I cannot share while the other person is sharing. So Adam,
right.
Stop sharing.
I can't stop. I just need to do it. All right, let me get back here. And it's not letting me get back. There we go.
Yeah, thank you. Okay, let's see if I can get up here now.
I'm glad we didn't have to kick him off.
Okay. That was such a nice talk. I'm a huge believer in these big data collection and all the great information you can get from those. So, okay, let's move on to early intervention. I actually changed the title to a little bit to earlier intervention, what is possible in cerebral palsy. Okay, so the really exciting thing in science is that there is some amazing possibility here for early intervention. And years ago when we were practicing in cerebral palsy, we didn't believe we could change the brain. And so we had a whole entirely different approach. So that's why I say we've gone from futility to hope. There is some research by Brian Kolb, who's a neuroscientist in Canada, who showed that neonatal rats with brain lesions, if you just create the lesion, they will recover a little bit on their own, but they still have deficits. But recovery, full recovery of the brain lesion is possible with tactile stimulation early after birth, 15 minutes a day, 3 days a week for 2 weeks. So this is really amazing evidence. And what he found was that the mechanism was really related to this upregulation of fibroblast growth factor that's in the skin and brain. And then you can actually inject this factor into the rats and get some bit of recovery. So this is really incredible evidence from the animal world, but what is possible in humans? So this study is even more related to CP. This is the work done by Friel and Martin. And what they did is they developed a unilateral lesion in kittens. And they were trying to look at the plasticity in the motor system, trying to get some idea of what's possible in this model. And they found that the brain plasticity for the motor system is really at 3 levels. And the first level is at the spinal cord interneurons, where we actually develop these reciprocating oscillators or central pattern generators that help us move our limbs. And this is the earliest period. And the window for this is about 3 to 6 months if you make it equivalent to a human. The second is basically the M1 map in the motor cortex. That window closes a little bit later after the first year of life. And then the third longest lasting window is the cortical spinal tract that goes up to 2 years, where the baby is actually, all the fibers are being myelinated. So a lot of people will promote, for example, locomotor training up to 2 years to really take advantage of this. But what they did here is they actually applied an intervention to groups of kittens. And I'll show you the data here. So these right here are just the different models on the top of the plasticity. This is with the spinal cord. This is no treatment, so nothing happens. This is motor recovery. With constraint therapy only for the upper limb, there was some plasticity in the corticospinal tract, but nothing else changed. If they did this training later, they got more changes. But if they did it early, in that very early window when they reached the spinal interneurons, they recovered the brain lesion and they had full motor recovery. Again, these are hugely impactful studies. So what do we know about brain injury and plasticity in CP? Well, we know that early development is obviously different than later. We know that there's an overabundance of neurons at birth, and there's a selective atrophy or survival, and about 50% of the neurons die in infancy. And this is due to sort of a competition between synapses and synaptic strength. And motor activity or lack of shapes these processes. The brain does not receive the inputs it's expecting to develop normally in CP. But we know plasticity is far greater in younger nervous systems, but they may lose capabilities that cannot be recovered unless you intervene in time. And this is the example here is a Hubel and Weasel study that won the Nobel Prize, where they covered one eye of a newborn kitten, and they did not develop binocular vision in that eye. So what we want to do, so this really got the field excited that we really need to get in there sooner. If we need to be in there by 3 to 6 months to really make a huge difference, that's a big challenge. And we do know that all the different aspects of development have their own critical windows. And for the visual system, interestingly, it's right around birth. And for the motor system, it's later. And for higher cognitive and language, it's later. But what you want to do with these red arrows here is intervene as it's emerging, not wait till it peaks. Oh, it's just going on its own. The same thing. So you can see in the motor system, it starts around 3 months. So what kind of evidence do we have for physical and occupational therapy in CP? Well, this is a recent re-review by Novak where she did her traffic lights, and we have a lot more evidence accumulating all the time. And the green bubbles are basically things that are effective. With the bigger the bubble, the better the evidence. And then you see a lot in yellow or orange where there is some evidence, some raises higher than others, but the evidence is still a little bit weaker and inconsistent. And then there are clearly some things that are shown not to work. But this is for all ages of CP. If you go to the box I created at the end, they also show the evidence for early intervention. And all of a sudden you see very little evidence. Nothing's either green or red. We don't have enough evidence to say something works or doesn't work. And there's, and everything is weak and inconsistent. So why aren't we finding in all this possibility, why aren't we finding that more is effective? Well, maybe we're not doing the right thing. Maybe we're doing the right thing, but not doing it intensively enough. And maybe we're not doing it at the right time. So this is an article which just got published last week that we completed an evidence review, again, looking at early intervention evidence. And what we wanted to do was to do a systematic review of all the systematic reviews, which is now called an overview. So we looked at this, plus we also, since the last review was 2017, we also reviewed all RCTs published since that time. And our goals were, number one, to update the evidence for us because we were doing a new project, and then to evaluate the effectiveness to get any suggestion, does earlier seem to work? And then also, since we know there's very few studies that start that early, we wanted to use this to serve as a benchmark for this big change that's happening in our field, which is trying to identify children earlier. We included infants 0 to 3 with or at high risk of CP. And we found 3 reviews that had 46 unique studies. 4 of those were RCTs, 12 had comparison groups, and then we identified 6 additional RCTs. And I'll tell you the results in a minute. But the big thing that's happened in our field, and I only have one slide for this, but it's critically important, is this idea of diagnosing CP early. And this was, again, a consensus conference published by Novak et al. In 2017. And in children that are high risk, because we don't routinely do developmental surveillance in all children, before 5 months chronological age, the most predictive tools are using MRI, the general movements assessment, and the Hammersmith infant neurologic exam. And you can see how sensitive these tests are. So we can do a really good job of identifying these children before 5 months. And then after 5 months, the tests are a little bit different. General movement is really specific to look at fidgety movements in the 3 to 5 month range. So what did we find in our review? Well, we found, to suggest whether early is better. Well, we found 2 RCTs on infants that showed positive motor outcomes. And the one was GAME, which is done by Kathy Morgan and her group, Goals, Activity, and Motor Enrichment. And they started the infants between 3 and 5 months of age. A second study was done in Sweden on constraint-induced movement therapy in children with unilateral deficits, again, starting at 3 months to 9 months, and they compared theirs to an infant massage group. So these are the only 2 studies that really show efficacy or some level of efficacy with small to modest positive effect sizes. In those less than 3, constraint is no better than bimanual or intense OT. So just saying that just because constraint study doesn't mean that bimanual therapy doesn't work in infants as well. We also found evidence in the review that environmental enrichment increases cognitive and sometimes motor outcomes. And what we also identified is there are 6 now published RCTs that are all implementing these early detection guidelines. So once those studies are done, we'll have a much firmer answer soon. So I kind of distilled this all down to what I call the 5 E words of early intervention. And I kind of did this as a sort of a joke to Peter Rosenbaum, but it just seemed to work out for infants. The suggestion here, he's done the F words. I can't remember all of them: fun, fitness, friends, family. But I said that babies are too young and innocent for the F words, so we have the E words. And the first E is as early as possible. Second is active engagement of the infant is essential to learning. The third is enriched environments because they encourage infant-initiated exploration. And the last is that we need to coach parents and caregivers to integrate activities into everyday routines. And so I'll just review each of those quickly. So there's increasing evidence for strong links between cognition and motor training and development. And this is really the whole idea in rehab, that we need to be mentally engaged, paying attention, and motivated to do a task for us to learn it. For babies, we can facilitate social and verbal and motor engagement, but the baby has to be ready. Everybody knows you can't just put a baby on a schedule and say, okay, we're going to play now. The baby's going to have to be ready. When the baby's done, they're done. So it's really, tricky to be able to give the children enough intervention. And we also know if a task is too boring or too difficult, the child will rapidly lose interest. And what they found in children with CP, for example, with kicking, since kicking and kicking hard is hard for them, they found that where typically developing babies will increase their kicking over time across months, the children with CP will actually decrease it. And so you just think about the fact that they're getting less activity than they really need to develop. Environmental enrichment, this was a review done by Morgan, one of their systematic reviews we looked at. And this just shows a positive effect size here, everything to the right of the line, for studies that incorporated the principles in an enriched environment. And movement is, of course, the way that babies interact with the world. So the motor challenges are a really important component here. And again, there's extensive research in the animal literature for brain injuries showing that enriched environments make a major change in the brain pathways. And of course, babies are different than us. We can go to the environments when there's no COVID. We can go out to different environments, but parents and caregivers have to create the environment for babies. And this is their definition, but again, they point out that it's really the voluntary and challenge aspects of the environments that are crucial, that they motivate the child to want to move around and get to things and play with things. And the motor opportunities are a critical success factor. Exploration is really that the baby needs to do it. You can't be moving a baby passively and they have big changes in their brain. And babies are little hypothesis testers. They're always trying to problem solve and learn how to do things. And babies, as you know, make a lot of mistakes. They drop things, they fall, but that's how they learn. And so they have to learn the sensory consequences of those movements. And they also have to perceive their own sensory feedback. And this is why we realize that external stimulation, even therapist hands, can be detrimental to the learning process. And there's some nice studies to show that. And again, children with movement challenges may need special strategies to make exploration easier for them. This is really the tricky thing in CP. So what are some of the strategies for kids with CP? One is to try to increase their strength, to really work on promoting their extensor strength. The second, in the short term, is to make the task easier, but not too easy. So you need that just right challenge where they can do it, but not get frustrated. And the third is perhaps one of the things we're pursuing is to incorporate novel devices to encourage movement. They either can magnify the intent. This is the first crawling devices by Tubi Kolobi, where the child wants to go in a certain direction and the motor actually magnifies that intent. So the child doesn't have to try too hard. The next is putting babies on treadmills. It's Dale Ulrich's work. And the third is this Linda Federer's kicking device where the children are motivated to kick higher because they activate music. So many people are trying different strategies. So let's just talk quickly about the role of strength in development. Infants have all of their adult fibers, but their muscle cells are not developed. And this is why we don't get up and walk like animals do when we're born, that our muscle cells just can't sustain that. And muscles like the brain and the bones need activity to develop. And we know there's two rate limiting steps for walking. One is this anti-gravity strength, and the other is your postural responses. And we have evidence of this just from looking at the cultural practices and what an effect they've had on motor milestones. The whole back to sleep now has led to delayed walking onset. Many children now don't crawl, and a lot of children don't like being on their tummies. So how early do these changes start? Well, this is work done by Noelle Moreau, who's one of my postdocs, where she looked at full-term infants compared to healthy preterms and high-risk preterms at 6 weeks of corrected age. And she looked at medial gastroc thickness. And this just shows the cross-section of the muscle. And this is a healthy preterm. They were already 50% less thick of a muscle than the child who was born full-term. So just, basically being born early and not being mobile enough, not being in your mom and actually doing resistive exercise against her tummy, which is what babies do, they don't develop their muscles. And that's in healthy children. So I'm going to show you a device. This is a harness that we've used for a study that we used several years ago. And I will just tell you about the study real quick. We had 5 participants. This was the pilot trial. They were all at least a year, probably more like 18 months. They all had 4-month motor delay and they were not yet walking. So we did this mobility training with this novel harness that actually is a smart harness, which means that it can unweight, but it doesn't support. So the child can move up and down at a certain corrected amount for their gravity. But it allows them to make it a little bit easier if they're already weak. And we really hope this would encourage self-movement and more variability and flexibility and allow them to make these errors and learn. So let's see here. So this just shows you the little, it always likes to have this noise. So here she is, she has bilateral CP, and this is how she's learned to get around. She's figured this out. So she's in a W sitting position, she scoots around. You see a lot of overflow in her arms, and this is what she's been able to do. Let me just stop this. And you can see the same little girl in the same developmental period in this harness. And you can see they act a little crazy, but the interesting thing is that babies wanted to be in the harness because all of a sudden they felt like they could do so much more. And if you look at this little girl now, you wouldn't guess that she even has CP. And so we did a training here where they came in for 6 weeks and trained 4 days a week in the lab to see how that changed their motor development. And what do you see here? So this is the baseline period where we tested them every 2 weeks for 6 weeks. This is the period where they did the intervention. And this is the period, the follow-up period. And we looked at their GMFM during these periods. One little girl started walking during the baseline, so she had her biggest change there. But I think you can appreciate that the other 4 children actually had an increase in their motor development rate during the intervention. So what's happened from this is Laura Prosser, who was my postdoc at the time, has now completed this study, RCT on children over a year. And our lab, we've actually now developed a new prototype of a more portable harness, play space, that can be used in PT clinics that has both crawling and standing harness. And then we want to start a trial hopefully within the next year on children 4 months and up. So the final thing is every day. We know that precise dosing data are not available, but obviously 1 hour a week for early intervention is not enough. And we know that parents have the greatest impact on development and through how they handle and interact and play with their child. And as I said, the infant dictates the dose. So you have to really be ready when the baby is ready. And the challenge is, what do you do before functional movement even emerges? Well, the one thing you can do is really do extra tummy time. Put the child upright or standing, even if it's not functional, but just to get weight bearing through their legs as much as possible, and to encourage any stepping and any movement. You can use water or toys or music, anything you can think of that encourages movement amplitude, amount, and variety. And then using these wonderful toys that are out there like wrist rattles and socks that have jingles, that these again can be motivating for babies with CP. And finally, there's many things on the horizon. Valerie mentioned this one where we're actually looking at EEG during the emergence of motor skills. But the thing that we're learning, it goes back to Adam's point of heterogeneity, is that each child with CP has their own neural signature of how they respond and develop after brain injury. So this is something that we really need to understand for each child and basically start developing personalized treatment. So thank you. And I'll stop sharing so I don't get in trouble.
I won't kick you off, Diane, I promise. Thank you very much.
Sure.
All right, our next presenter is Dr. Kruer. So take it away, Michael, if you can put your slides up there. Sweet, that was a good transition. You're good to go. I can see your screen.
Okay, can you guys hear me okay?
Yes, I can.
All right, well thanks so much everyone for the opportunity to give you guys the last update of the morning or the afternoon, respectively. And this one really is focused on biomedical interventions in cerebral palsy. So I think at this point you've had a wonderful overview from Adam about some of the ways in which motor function can be measured and assessed at a pretty sophisticated level in order to decide which interventions are appropriate. And you've heard now from Diane talking about some of the exciting new avenues in early diagnosis and early intervention. I'm going to close off the presentations by talking to you guys about some of the medical aspects of cerebral palsy and some of the more recent advances. And given the scope of time, I'm going to focus in particular on genetics. And so stated simply, brain development is pretty complicated. So what you see here in this video, this is a time lapse collected over the course of more than a week of a bunch of isolated rat brain cells in a dish. And what you can see is that although they start off as individual neurons, they rapidly form these connections that whiz across the screen, reaching out and connecting with other brain cells in the dish. Sometimes these connections are pruned back or refined. In other cases, they're strengthened. And hopefully what you can take away from this is a thought that I myself and many others in the field have had many times, where if this is a handful of rat brain cells in a dish, just think about what's happening during the course of normal human brain development, where there are literally billions of neurons doing this very same thing and organizing in a very precise way. It's remarkable that anything with neurodevelopment ever goes right. And so as everyone is familiar with, neurodevelopmental disorders frequently overlap. So I probably don't need to tell this audience, but during my medical training, I was taught to think about different domains of development, with cognitive development, sometimes being disrupted and leading to intellectual developmental disabilities, language and social emotional development, sometimes being impaired and leading to autism. And cerebral palsy really refers to interruptions, if you will, or disruptions to the physical or the motor stream of development. But I think what we're realizing more and more now than ever before is that there is a huge overlap of these conditions, not only at the clinical level, when we see these patients come into our offices or into the hospital, but also at the level of the underlying biology of the brain and how shared biology actually links many of these conditions. And I think that despite some of the exciting interventions that you've recently seen from a medical standpoint, we haven't really had new medical and surgical treatments for CP in decades. And so in many cases, what we're doing, I think, from a research standpoint, a clinical research standpoint, is trying really to understand how best to use the tools that we have at hand. And so I really think that this amounts to trying to develop a balanced portfolio when it comes to research, but also looking to research to lead the way for improvements in clinical care. We want to take the very best care of the kids that we can today, but we also want to be learning from every patient and continuously pushing the envelope. So again, you've heard some very nice discussion of how early diagnosis and early interventions can have substantial impacts. We also think that learning how to better apply some of the tools we have can have a high impact in the short term. And this really goes back to what Adam was saying about how different centers might actually approach the same problem very differently. One of the foci of clinical research in cerebral palsy currently is really trying to identify and define gold standards of care so that we can optimize outcome for the kids. But again, in terms of having a balanced portfolio, we really also need to be thinking about the long term. We need more in the pipeline. And so what I'm going to be talking to you about is in particular how genetics might help in that regard, how some of the recent advances in understanding the genetics of cerebral palsy can lead us to repurpose some of the existing treatments that are already in existence, as well as developing completely new treatments. And I think that it's an exciting time where we're starting to think big about medicines that are not just trying to suppress symptoms, but are actually focused on the fundamental problem, trying to address where neurodevelopment took a wrong turn, for example. This carries over from a biomedical standpoint into new devices, things like neuromodulators and indwelling pumps, not to mention brain stimulators. These devices are not science fiction. They're actually something that's available today, although we're still trying to figure out the best ways to use these. And then finally, what about things like stem cells, gene therapies, CRISPR? Is this something that's realistic? I think that the evidence is starting to accumulate that although it's not ready for prime time quite yet, we're starting to move in this direction. And so you might ask, well, why genetics? Well, genetics can actually provide a roadmap for research and can really provide a stepping off point to know where to begin in order to tackle some of these complex neurodevelopmental challenges. And so when we're talking about genetics, one question that often comes up was, well, what exactly does this mean? And just to take you through this from the standpoint of an analogy that I really like. When we're talking about genetics, we often refer to a person's genome. It's kind of a cookbook that contains all of the individual recipes needed to make a human being. And for most of us, it's thought that our genomes comprise about 20,000 or so of these recipes. And each one of these recipes does something important within our bodies to help it develop, grow, and function. And so each of these recipes in turn, each of these genes is written in the DNA alphabet. And ultimately, what we're looking for is we're looking for that recipe to be used to do something specifically within our bodies. So for example, a given gene might contain the instructions for how to make a chocolate cake. And just as if your cookbook recipe for the chocolate cake had a typo, it was missing a page perhaps, or had a typographical error so that you thought you needed 4 eggs instead of 2 eggs, that could affect the way your cake turns out. Well, the same thing with genetic mutations. These can be misspellings, sometimes in just one of those DNA letters out of 3 billion. And that can sometimes make the difference between health and disease. So you might ask the question, again, why does this matter? This is perhaps interesting, but why is this relevant to patients and families with CP? Well, the evidence is starting to accumulate, and I think we're on the initial wave of this, but we're learning things from genetics that not only have important research implications in terms of how we understand where brain development takes a wrong turn to lead to CP, for example, but also starting to understand how genetic changes can have individual impacts on the patients and the families that we're treating. And so one of the things is, as a doc who cares for some of the kids with CP, this is a huge portion of my practice, and something I'm very excited about because there might be immediate clinical implications in some scenarios. And this can actually affect the way that we diagnose. It can sometimes affect treatment options, and it can sometimes lead us to avoid potential complications through preventative medicine, which is very important as well. So as Valerie briefly mentioned, we've collectively as a field of CP genetics made a lot of progress in the last few years. I was very fortunate to be a major part of this paper that was published in Nature Genetics, in which we found that there was firm statistical evidence that genetic mutations not only lead to CP rarely, but they actually lead to CP in a large proportion of cases, more than we would have thought several years ago. Within some of the recent work, we've identified new genes that seem to lead to CP when they pick up a mutation. So if just one gene out of the 20,000 picks up a typo, that can affect brain development enough that it in and of itself will lead to CP, even if that person has no other risk factors for CP. The work that's been done recently has led to the conclusion that there are probably hundreds of genes that might lead to CP, and that we're perhaps only scratching the surface of the iceberg, and that many of these genes await discovery. And although there are many, many different genes that are involved in CP, and this can be somewhat overwhelming, it's nevertheless an exciting time, because although we're finding many of these individual genes, we're also finding that they're not just random. In fact, there are several key pathways that have already been identified, and these may control early brain connections. And so in this movie here, if you remember those neurons that I was showing you in the dish in the very first slide, how they were growing and forming connections. Well, this is just a single neuron, but hopefully you can see that from the center, from the cell body of this neuron, there are waves. And these are actually waves of a compound called actin. These actin waves will drive forward the processes of the neuron and actually cause it to grow from a pyramid-shaped structure into more of a star-like structure. And so it's these waves of actin that in many of the individuals in whom we've identified mutations, we've found that they have a disruption in one of the genes that controls these actin waves. If the very earliest processes of neurodevelopment are then disrupted by this mutation, that can affect the way that those neurons form very early on in development. And we think that that can fundamentally lead to changes in how the brain is wired up and connected, i.e. lead to CP. So this is, of course, extremely complicated. How does one fix something like that? Well, it's no easy task, but nevertheless, it's led us to some very exciting new research possibilities where the work is starting to focus, I would argue more than ever before, on the possibility of trying to address some of the fundamental changes in development that happen early on. So again, trying to focus on the core problem rather than just controlling symptoms. I think it's also interesting that when we look to how this can affect individual kids and individual families, we're starting to be able to identify a genetic cause for many of the individuals that undergo gene sequencing today. So this is not just a research phenomenon. When kids will come and see myself or one of my many colleagues in the clinic, we're able to actually do genetic testing, and more than ever before, often we're able to identify a genetic cause for that patient's symptoms. One of the corollaries of this is that we're continuing to identify new disease-associated genes. So even though it was thought that the era of gene discovery was long over at one point in time, we're still continuing to find genes that seem to lead to CP at a relatively high rate. What's more, we're in fact identifying a genetic cause for many of these individuals, but of those for whom we're able to identify a genetic cause, we're starting to find that in a surprising number of cases, it's actually changing what we do clinically. And so the latest numbers are fluctuating as the study is ongoing, but somewhere more than 1 in 5 individuals for whom we find a genetic cause, this will actually be actionable, meaning that we might be able to avoid a potentially dangerous risk factor. We might be able to steer them in the right direction in terms of their treatment, or we might, in fact, actually be able to apply new treatments. And this is of course, the holy grail of biomedical interventions for CP, but, and this is not happening as often as we would like, but it is happening. And the frequency at which it's happening is starting to grow. And so this represents a very exciting time in the field. So what do I mean when I say that genetic findings can actually influence treatment? Well, I think this can take several forms. As I briefly hinted at, this can mean that we reach for the best treatment off the shelf first. Unfortunately, clinical medicine historically has been fraught with trial and error. So instead of going through a whole series of possible medications or injections or other interventions, we can now reach for what might be the best treatment first. I think that excitingly, we're starting to find that we can sometimes repurpose existing treatments. So this means using medicines that are not typically used for patients with CP. But now that we have new insights into what's causing that person's CP, we can pull this medicine off the shelf and use it in an off-label fashion for CP patients. As a pediatric neurologist, most of what I do is off-label anyway, so this is familiar territory to me. Sometimes this is allowing us to begin to start predicting responses to surgeries. So some of you have heard me talk in the past about deep brain stimulation, which is a form of neuromodulation that involves placing electrodes deep into the nuclei of the brain and using a neurostimulator in order to help reduce movement disorder symptoms and hopefully help improve function for that person with CP. Well, one of the most difficult decisions that families often face is trying to decide whether or not to go ahead with what amounts to an elective brain surgery for their child that could help a great deal, or the results might be somewhat disappointing. And so I think that there's still a lot of work that needs to be done, but there are some success stories already where genetics have been used to better identify individuals who are likely to respond to deep brain stimulation. And conversely, understanding the cause of a person's CP can actually help us make the decision not to use deep brain stimulation. Finally, myself and many others in the field are very excited about using some of the new insights, the doors and windows that have been opened into the neurobiology of CP to help develop entirely new treatments. So I think it's starting to be a very exciting time for the clinical treatment of cerebral palsy. It's starting to be the dawn of an era where personalized medicine for neurodevelopmental disorders might not just be possible, but might start to be used with increasing frequency. And this is a paper that recently was published in one of our neurology journals, a well-respected neurology journal, where they talked about how to perform what are called N-of-1 studies, using treatments that are tailored for a very specific rare neurodevelopmental condition or a rare genetic cause of a relatively common neurodevelopmental condition like CP, epilepsy, or intellectual disability. And these N of 1 trials involve very carefully applying a novel treatment in a controlled way to a patient in order to see if some of these new therapies might be helpful in treating their symptoms. So what does this look like? Well, this is a patient of mine, and I want you to just watch him walking down the hallway. It's a remarkable young man who continues to be ambulatory despite significant movement disorder, despite his CP. But yet he was found to actually have a mutation in a single gene. And as it turns out, individuals with mutations in this gene, which is called the ADCY5 gene, have been found to be responsive to caffeine. And so this was found out by accident, but this actually makes a lot of sense given what we know about this gene and how it functions in the deep nuclei of the brain. As it turns out, for some patients with ADCY5 mutations, caffeine can be remarkably effective in reducing their symptoms and improving their movement disorder. And so this was picked up by the press. And you can see in this article from Newsweek how they talk about how doctors were using coffee to treat this boy whose life was, quote, ruined by a genetic disorder. I think that this is a very specific example. And it's not that every one of our CP patients is going to be able to be treated with double espressos. But in the limited amount of time I had, I wanted to just give you an example of some of the outside of the box thinking that's starting to be utilized more and more in clinical medicine as we're starting to understand the cause of our patients' symptoms and conditions at an unprecedented level. And so in conclusion, I think that molecular and cellular advances are really starting to shed new light on the neurobiology of CP in exciting ways, but also starting to impact treatment. And I think that at this point in time, I'd like to make the case that I hope as a group, we can continue to make a focused investment in research and intervention because like not seen before, we could make an appreciable impact and help galvanize advances in this field. I think it's a very exciting time in CP research. So with that, I'll turn it back to Valerie, and thank you very much.
Thank you, Michael. So we actually have a lot of questions in the Q&A. So I'm going to start with one that I think is great and one of the first ones that came in. It is from Rhonda, and she was asking what types of research is being done on and for adults with cerebral palsy. And she had what I think is a great comment. The child with CP becomes an adult. So can either three of you speak to that?
I can start. I saw that from Rhonda, and I thought that was a great quote as well. It's obviously, yes, that's great. And you've heard a lot today about the research we're doing on kids with CP because it's a childhood onset thing. But it is important that when we're designing our experiments, that's kept in mind. A lot of the interventions that we do are done in childhood. A lot of the results that you saw from the stuff that I presented, that Diane presented, were months to maybe a couple of years in duration that we're measuring the outcomes. But we want to look, the goal is not that the child's going to look good a year from now. The goal is that this child will be able to function well as an adult. And so we need to be able to go and measure that. A lot of times that doesn't happen. I think, in developmental disorders, we do a little bit better at that, at, seeing kids long-term. There are other things like, you have an appendectomy and you never come back and see your doctor again. They just kind of assume it worked. But we want to get these people back. And so the issue that we have run into is actually a cost thing. To be able to come back and measure these people when they're adults, the insurance companies need a reason for that. And as kids, the reason is intervention. As adults, we don't see that as much, and so we struggle to get that. And so our focus lately at our institution has been actually, okay, we're gonna go out, we're gonna get the grants that we need to be able to contact people in their 20s or 30s and get them to come back and see how they're doing. And so we have started to do that at our institution a little bit. But I think there was a great point by Rhonda, and a lot more needs to be done about that.
Briefly add, awareness is starting to increase as well. Part of the challenge in the medical world is that there's sometimes not the availability of individuals in adult medicine that are quite as familiar with CP in certain areas of the country. But I do think that it is being recognized. It is an area of focus for a lot of different groups, especially given the declines in function and mobility and the increase in pain that individuals with CP will sometimes experience as they transition into adulthood. So I think that it's an important problem, and yet another area where I think there's an opportunity to make a difference.
This is Diane. The other thing is I think we have a responsibility, because now we're starting to understand what happens to adults. Before, I used to assume that their life just continued the way it was when I saw them at 18, but that's not the case. And so as therapists, we need to recognize that, and recognize that half of those people are going to lose their mobility, and they're all going to experience pain. To educate them, I went to a workshop with a CPRN years ago when they're setting research priorities, and there was actually a lot of anger among the parents and the patients that we didn't tell them, and basically we didn't know. So I think that our responsibility is prepare them for that and say, yeah, you can do these different treatments, but you have to always keep yourself physically active. You have to keep yourself strong. You have to monitor your joints, and sort of give them more agency over their own care.
All right, thank you. I have another one here, and it's coming from James. Is there any research done with respect to cortical visual impairment and how that impacts the individuals we serve?
I can start. I think that also there was another question too about center of movement and accelerating the body. And I think all those things play a part together in how people move, and are important to be able to measure and quantify as we're talking about this. There's some really interesting stuff with dynamic walkers of having these very simple robots without a neuromuscular system, without any kind of neurology, that are able to walk. And so there's no proprioceptive feedback there, but they're able to accomplish the task. And so what we want to do is, as we're looking at our interventions, knowing that we do have a very complex neurology, like Michael showed us, that there's a lot of different ways that it manifests, the visual, the proprioceptive, the balance. And so we're working on things like, can you stabilize someone and see if that reduces how much energy they need to hold themselves up. As you perturb those things as they're walking, perturb that center of balance, is that changing how much energy they use. And so we don't know enough about this, but we are certainly looking into it.
Yeah, I would just add, I think that there's increasing recognition too in the advocacy community that I think sometimes these things get placed into silos. So for example, Michelle Schusterman, who's a parent advocate, wrote a great article a couple of years ago about her child's CP and how her child is her child, right? That's who she is. She's a complete and very complex and unique individual. She has all these wonderful qualities, and then she's got these challenges. And out of those, CP was one of the ones that was originally focused on when she started meeting with her therapists and her doctors and so on. But that wasn't the only issue that her daughter dealt with. And so thinking of these things in terms of interlocking pieces of the puzzle is something that I think is starting to be recognized more and more. Sometimes a person has, quote, just CP, for example, but many times they have overlapping, interrelated neurodevelopmental conditions, and it's very important to see the whole person for who they are.
So the next question is actually coming from a board member, which from UCP, which is, and it just moved on me. So hold on for a second. I got to find the question again. So what do you envision for CP research in the future, and what role can UCP play? And that'd be a great answer from all three of you.
Well, sure. I am very excited about these long-term studies, getting people back as adults and seeing if we can determine what it was about their care pathway that helped them or hurt them, and just kind of establish what is it that are your issues. And then we can work backwards and say, you know, when we intervene earlier, what is it that our focus should be? And then going back to Michael and Diane, that we need to be able to then frame the conversation we have with the parents that says, okay, these are the treatments that we have, and this is what you can expect going forward, so that people then know what it is that we're trying to accomplish. So I'm looking forward to that. And I think, you know, like I mentioned earlier, it's hard to get funding for that. It's hard to get those kind of things paid for. So if there's grants, awareness, you know, spreading the word to people who maybe didn't get all those interventions that a kid coming to Gillette would get, to be able to reach out and say, you know what, can we measure you and see how your life has been, and get an idea of what to expect about the natural progression of things.
So I can speak from the motor aspects. You know, I think rehab has really sort of flipped around, and we used to have a bottom-up approach where we took care of the periphery because that's all we could do. But now that neuro rehab is really doing more of a top-down approach, we're actually trying to deal with the brain injury itself. And so we're trying to augment plasticity, but there's, you know, what we're realizing more and more is that the intersection of technology with training and things like directly stimulating the brain and directly, you know, augmenting those pathways in different ways. And that includes TMS, TDCS, you know, all these electrical stimulation parameters, where they're actually really rising to the top of showing a lot of evidence. And then using things like the brain-computer interface, but flipping it to use it for rehabilitation, where you're actually having people iteratively change their, the way they use their brain to control their movement. So, you know, I'm sad that technology is going to be the answer in some ways, because I want things to be in the home and easy and cheap. But, you know, if that gives you something that you can't get any other way, I think we have to embrace it. And you know, if the goal is for motor to help people go through their lives more easily with less restrictions, I think that that's going to be a big part. Technology is going to be a big part of it.
And I guess I would, you know, advocate for kind of a balanced portfolio. I think that hopefully you've gotten a sense from the presentations today that there are things that can be done that may have immediate impact, or at least short-term impact with some of the tools that we have at our disposal now. We need research and support in order to help us utilize them to the fullest extent. So being able to recognize kids as having developmental disorders like CP at an early point, trying to intervene early in development, like Diane was telling us about. These are key opportunities. But I think also trying to think about some of the other exciting avenues that a focused investment could actually play huge dividends in the long term. It's an exciting time in CP research, and I think it needs to unfold in a focused and a thoughtful way. But I think that there are multiple different opportunities to potentially have a major impact.
All right, I think that we are coming to the end. I'm going to just go through our Q&A one more time and make sure I didn't get a burning question that I should get from you. One thing that has been asked, and I would love for us to be able to share this. It sounds like Diane, you're being asked if you have some shareable statistics or research that they looks like one of our affiliates could share with pediatricians on why to refer to early intervention when a child is so young. So is that something, I know that these is being recorded now, but is that some information that you could share?
So I know people that could have that information are actually making it, like Natalie Maitre. She's really doing a lot of work trying to educate pediatricians and to be aware and to not be doing this wait and see attitude. And in her state of Ohio, they made a huge impact on early identification there. So I think there are champions for sure. You can share the article by Novak on the early diagnosis, the consensus that explains everything and how to do it beautifully. And I think even the American Academy of Pediatrics is moving in those directions as well.
And you know what, I know those articles that Diane's sharing. I can share those with you, Cheryl, as well too. So it's very, and honestly, we can make those public to anybody who's interested. So I will get them also over to our development department too. Maybe I'll pass them past you, Diane, too, to make sure we're thinking about the same things. So, okay. All right, I think we're getting ready to wrap up. I want to thank you all, our panelists, for being here today and actually for the work that you do every day. It's making a difference in the lives of people with cerebral palsy. I do want to take a moment before I give it to Armando to be able to tell people about a special 3-part series of professional educational workshops that we have coming this June, so really soon, in September and then in December as well too. This series is hosted by United Cerebral Palsy and it's organized in collaboration with UCP's National Board, our research committee here, National Board of Trustees Ad Hoc Research Committee, that's the actual title here, Gillette Children's Specialty Healthcare in UCP of Minnesota, as well as my own home, UCP of Central Arizona. These 90-minute workshops, are aimed at professionals who are working with people with cerebral palsy, and the presenters are associated with our affiliates, and we encourage any and all our clinicians and affiliates, anybody who's interested, to sign up because the workshops are free and they will come with CME, so with some continuing ed units. So the first one is June 30th, and it features Dr. Tom Novacek, an expert on gait analysis. And so for more information or how to register, you'll need to find it at Eventbrite, but we promise, and you'll need to search in the 2021 Professional Learning Series. That would be what you would search for, Professional Learning Series. Or give it a day and you can visit UCP's website at ucp.org, and we will have the information there too. Just check under the events tab. So there are a lot of questions here. We'll try to manage those so people don't go without answers, but I think it's time to pass it back to Armando.
Thank you. What an amazing conversation, honestly. Valerie, thank you so much for moderating. And Drs. Kruer, Damiano, and Rozumalski, what a remarkable session. Thank you all for sharing some wonderful information. And we're encouraged of what can be in the near future. I also want to thank James Garcia for moderating the autonomous vehicle panel discussion. And my sincere gratitude to all of the UCP podcast participants, Carlos Gonzalez, Doug Cole, Miguel Ayala, for sharing their stories. And again, a special thanks to the sponsors, especially Mass Mutual, for their generosity, and my deep appreciation to the UCP team for their preparation on this virtual event and the behind the scenes collaboration. So this concludes our first day of activities for UCP's 2021 annual meeting. Tomorrow we'll be back using the same Zoom link with the keynote address at 2 p.m. Eastern time, or that would be the same as 11 a.m. Pacific time, by Dr. Neil Lamb, an award-winning science communicator who leads educational outreach efforts at the Hudson Alpha Institute for Biotechnology in Huntsville, Alabama. The subject of Dr. Lamb's presentation tomorrow is a very timely overview of the impact of the pandemic on the disabilities community. Like today's event, Dr. Lamb's presentation is free and open to the public. So we'll see you tomorrow. Thank you, everybody, and God bless.